Hi there, this is Ben with HCO Thrive, and today we're going to talk about our inpatient financial data. A pretty brief overview, some of the methodology I'll make another video for, but today I just really want to touch on what data sets there are, how to access them, and just a little bit of background information. So the first data set we're going to talk about is just the basic HCRIS data set. This includes a number of selected worksheets from the overall CMS data. Even still, even though it's a subset of what CMS releases, it's still over 1,000 variables, I think close to 1,100. And then the second data set is a more compact one. It's pretty much the core HCRIS variables, and then some financial ratio calculations and outlier identification. And overall, in terms of modifications to the raw data that comes from CMS in this case, it's pretty much aggregating subscripts, cost coding, and then giving variable names. And then, of course, stacking it so it's a longitudinal data set. So let's just give a real high-level overview. Like I was saying, HCRIS stands for Healthcare Cost Report Information System. Basically, its purpose is to find out how much it costs hospitals to give care to Medicare and Medicaid patients. So compare what was actually paid to the expected cost of providing treatment. It determines how much money the hospitals will get reimbursed from CMS. And then there are many other uses as well. Private insurance companies use Medicare rates as a starting point and then negotiate with systems above and beyond that. That was the overview. Now let's talk a little bit about the process itself. It must be submitted by the hospital's maximum of 5 months after the fiscal year ends. It's important to note that the fiscal year is going to vary. So like a lot of organizations, some of the fiscal year ends in July, and then for a lot of them it ends at the end of the regular calendar year. So that's something to be aware of. Not all hospitals are going to have the exact same time chunk. It's usually done by contractors. Uses a step-down methodology to find costs. Costs are derived from the general ledger and then classifies expenses as either allowable or non-allowable. And then these costs are sort of classified into groupings, and then you find a cost-to-charge ratio for each clinical grouping. The cost reports are organized by alphanumeric worksheets. I believe it goes A through most of the alphabet for hospitals. So this list is what we aggregate and what we take out of it. And this generally has the most interesting information. So you can see utilization, so how many discharges, length of stay, expenses. So A is the initial classification I was talking about on the previous slide. This is just an example of some of the general service cost centers. Then there's columns and you enter costs, et cetera, et cetera. C is the cost to charge ratio. EA, EB is for reimbursement, as you might expect. A is for Medicare Part A. B is for Medicare Part B. And then the G series is balance sheet, revenue, expenses, and whatnot. And has a lot of very interesting information. The only downside is there's not information about private insurance. There's a other category that includes private and then also uninsured, but you're never going to really get like detailed breakdown on anything else aside from Medicare and Medicaid. So here's a little bit of more information. One thing I haven't mentioned is that there's 2 forms. So 255296, that's the first one. That goes all the way to 2010, and then it changed over to 255210. And there's a bit of difference between variables. A lot of them are the same, but if you go back, you will notice there are some variables that are in the latter one that are not in the earlier one, and to some extent vice versa. So as I mentioned, and you can see in the table image from our website, there's a lot of variables. As I noted, the time range does vary. So one other thing to note about the time range is sometimes it'll be in 2 partials. So one might be 3 months and the other one will be 9 months, because what happens is they submit their cost reports, and then CMS might have issues when they get audited, and then they get sent back and they have to redo it. So That's part of the process as well, is finding old ones in the data, replacing those with new ones so that everything's up to date. So the financial health dataset is basically a subsection with the core financial variables. So everything from worksheet G, and then some other useful variables as well, utilization and some overall cost information. And then those are used to make a variety of common ratio calculations. And then we calculate outliers by variable within each cost report by size as well. So, obviously these numbers might be quite different for a small hospital as opposed to a giant one. So they're grouped into small, medium, large, and then we calculate standardized scores for each variable. And you can see an example of just a couple of the variables in this image of our documentation. So average length of stay, adjustment ratio. So again, common variables like that, especially those relevant to healthcare. In terms of the data page itself, I think the real thing to know is that it's a lot of data going back, over 30 years or so. So if there's 1,000 variables per year, and for hospitals, probably in this file, 4,000 or 5,000. So you can do the math. It's a big boy. So that's why if you want to browse it, it's only going to be a view for the last 5 years, because otherwise the table will never load. These tables take a while anyways, because most of the data sets are quite large. And then you can see it's broken down. So you get, current chunks of about 10 years exactly. So for all the full data sets, it goes back to 1995 coming forward. And each of these is about 140 megabytes. So just something to be aware of. When you unzip them, they will be about a gig plus. So be aware before you open it in Excel or read it into a software like Python or R without having enough RAM. So just be aware of the overall size.